Well, welcome. I'm Dr. Jason Porter. This is Dr. Casey Seenauth. We are here and we're going to actually teach or go over our presentation and webinar day together. Again, Dr. Seenauth and I and the other doctors have been deep in COVID for a number of months, and hopefully we can each add our own sort of feelings and experiences to this ongoing or complex situation we call post-COVID syndrome. It's also known as long COVID syndrome. For those of us who are new to our webinars, you should have an area for a chat. As an example, I'm going to just type in over here and say hello everyone and welcome. And if that works well, you should be able to see that on the right sidebar. If you are able to respond or ask any questions, then we're good to go. I have one question here. Is there a video? There is a video. You may need to make sure that your camera is on your individual personal computer.
Clicked on stage now?
Yes.
All right.
Can anybody else report? Can they see us on video?
Because mine shows just your icon. It doesn't show a video.
Oh, fascinating.
All right, we got several participants in the chat saying I can see you. So.
Oh, excellent. Well, it looks like we may have some people that can't see us. I'm hoping everybody can hear us. If you can't see us, don't be disappointed. We're just in our normal scrubs, nothing too exciting to see. We want to start, and like you say, this discussion is on COVID, and Dr. Casey is going to start us off with reviewing some of the current statistics and facts in COVID.
All right. So, we've been dealing with COVID for a long time. It seems like this is the gift that keeps on giving, so to speak. But I wanted to update you with some numbers. So we all know we had this big Omicron spike, which surged through late last year. In December was the spike, and we've been steadily declining since then. So you can see this blue line on our chart here, this Maricopa County numbers, and we've dropped significantly from the peak. Back then we were averaging, 17,000 new cases on a 7-day average, and now we're coming down a lot from that. Our 7-day average over the last week, they came down so far that Maricopa County doesn't even do a daily total anymore. They do a weekly average, and our last weekly average number was 480. So very good, promising that the severity, the contagiousness of this illness seems to be decreasing, either that or it's kind of run through the community to a point where just aren't that many people left for it to spread around to, which is good, but we do still need to remain vigilant. As we know, we had Omicron was a new variant, and that hit us by surprise. And actually, I was just listening to the news this morning. Folks over in China, in Beijing, or no, Shanghai rather, are showing an uptick in cases now up to about 4,000 daily cases. So as we know how this virus spreads around the world, that indicates we may have another wave passing through. Only time will tell. So there's an update there on those numbers. And as we know, the CDC has changed some of the recommendations for the community based on these lower numbers. So this chart shows Arizona counties. That green number does mean low risk of transmission. So as you're well aware, a lot of the restrictions have been lifted. So encouraging things like, mask wearing is no longer required in many places. The CDC still recommends, stay up to date with vaccinations, get tested if you have symptoms, and still requiring masks on public transport. But other than that, a lot of the restrictions are lifted now at this point. So that's good.
Someone's reporting they still, for some reason, can't get audio. As far as I can tell, our audio is working on this side. Apologize for that. Again, sometimes you need to go to your own settings and just make sure that your audio is not muted, either on the top bar of your computer or in the settings itself. I want to review this for a moment. And, for us, we always have sort of a framework in which we approach every disease and every condition that presents in our office. And as a foundation here, most of you have not seen this. This is new, but it is on our website, and we call it our EVD foundations. And these foundations, almost like bricks layered on top of one another, build a foundation for a house, a home, and these lead to what we would like to define as optimal health and health span. Health span we talked about in historically in regards to fasting, but this means we want to live a long time, but we want to live well, and we want to age well. And optimal life means we're living the kind of life that we'd like to, as far as feeling good, handling stress, having energy, sleeping well, and getting the most out of life that we can. We won't review all these, but there are articles for each one of these sections that you see here. And for us, the foundation will start with the diet, exercise, sleep, and fasting. The reason we start with these as foundational because they actually are things that individuals do on their own. You don't require necessarily a doctor, although a doctor can prescribe CPAP or prescribe fasting or even exercise routine specific to your needs. But these are things that people and individuals can participate in on their own. And the other impactful thing is, and Dr. Seenauth can back me up on this one, but when you look at the research, when individuals exercise regularly, eat a certain way, and perhaps, sleep well and participate in some form of fasting throughout their lifetime, each one of these individually has been shown to increase lifespan between 6 and 8 years on average. And so I don't know that if you do all 4 of these perfectly, that you're going to live 28 years more on average. That research is yet to be completed.
I like that math.
That's good math, yeah. But there probably is some synergism there, and so I think they're quite impactful. The second layer is hormones, methylation, metabolics, nutrients, and inflammation. These are things that we try to evaluate in every new patient that comes to our office. And if those are all working for you, you should have good health, unless you have some specific area that's in the third layer. Maybe you've got food allergies, or maybe you're toxic, maybe you have some chronic infection like Lyme. Genetics are involved here with mold reactivity, MTHFR, as many of you are familiar with, and of course other genetics that are that we're being exposed to. And of course we can look at brain health and anti-aging. And these are topics that we like to cover, and we'll cover more specifically in the future. But that gives you an idea of kind of our approach. In regards to, and so that you understand, COVID is an infection, a virus that comes, and technically it goes. But what we're finding is that many individuals, and the percentages are variable depending on the studies, but somewhere between 10 and 30% of patients who've had COVID will persist with some symptom after the infection is gone. That symptom usually, by definition, has to extend beyond 30 days from the initial infection. So the symptoms here that often patients complain or report, chronic pain. Don't know if that's joint pain and or if that's more like muscle or deep bone ache, do you know? It wasn't clear in the research.
I think from my experience, patients I've been talking to, it's mostly muscle
pain. Kind of like fibromyalgia.
It seems to be in the muscles, kind of a deep aching, which just doesn't seem to let up.
Yeah, that's my thought on that too, from what I could tell. Again, fatigue, debilitating or ongoing fatigue, malaise and lethargy, again, lack of motivation, fatigue, hard to get moving and going. Again, a very common symptom, brain fog and concentration problems. I've underlined those 2 symptoms as in our office, these are the 2 most common symptoms that we see reported by patients. Other symptoms that are out there, I haven't seen as many of these, but again, chronic ongoing shortness of breath and or coughing. We've heard and have seen in a few patients cardiac dysrhythmias, apparently AFib, atrial fibrillation, which is a condition where the heart starts to beat way too fast, and that has increased significantly, and cardiologist offices are being overwhelmed by that increase. We have sleep issues, and then other mood conditions, anxiety, depression, headaches, hypertension, some GI discomfort, loss of appetite, and even weight loss. Again, the children seem to report more GI issues if they have chronic ongoing symptoms. Some information to know that, are you one of these individuals, but some ideas that have come out in the research thus far. The risk increases with the severity of the initial infection. So as an example, 50% of hospitalized patients with COVID have at least one persisting symptom. 50%, so meaning half that were seriously ill, will have an ongoing symptom. 27%, though, of non-hospitalized symptomatic patients, meaning you had COVID, you had symptoms, but they weren't bad enough to put you in the hospital. 27% will have at least one ongoing chronic symptom. And again, as we said earlier, children are more likely to have GI symptoms. Someone did ask, while we're talking about symptoms, someone asked, what about 90 days after and losing your hair and smelling strange random smells? Interestingly, those were not included in the most common reported symptoms, but again, I think the research is in its early stages. We can certainly say that we've had patients in our office who report having loss of smell, which has been very, in a way, debilitating in its own way. If without the smeller, without the nose, our taste and recognition of joy in eating certainly is diminished. And in some cases, it really takes the joy out of it. And we see, and that explains some of the weight loss that we see. And again, I can't say that we at this point know of any cure for that condition, but we have seen some patients where it's starting to return and change. Again, I'm curious to see other people. I've recommended lately maybe individuals applying, this is not scientific, so applying menthol in the inside of the nose to apply something that people recognize as, sometimes not an unpleasant smell, but a strong enough smell that we can start telling our brain this is menthol. Hopefully, we may need to have our brains rewired in some way so it can begin to recognize those natural smells or things that we recognize in time. But this may persist for some time at this point, and again, no known cures, although a lot of people are trying to figure out what to do with that next. By the way, this will be recorded, and we will send it out again in the future for those who are having any difficulty with video or sound.
All right. So one of the big theories here, and there's a lot of theories of what the mechanism is of this long COVID, post-COVID syndrome, what causes it. But we always have to kind of consider our old friend inflammation. Seems to be at the root of so many of the disease processes that we treat. But because it's ubiquitous in disease and pathology, we have to consider what role is inflammation playing in long COVID symptoms. So we know that inflammation, it's the boogeyman, but it's a required and necessary aspect of our lives. If we didn't have inflammation, we wouldn't be able to survive the onslaught of things that are in our environment that want to interfere with us. The way that our immune system is activated to fight off infection is through inflammation. But we start to have problems when inflammation goes from this transient process that responds to a threat and becomes a chronic problem that doesn't switch off. So one of the ways that our body signals to respond in the event of an infection is to release cytokines, which are chemical messengers. They're proteins that run through our bloodstream and recruit our immune system to travel towards the infection. And those cytokines in our tissue, they promote inflammation. So that's going to allow a lot of beneficial things. It's going to allow our white blood cells to be able to move through the tissues towards the area of that's affected. It's going to allow the macrophages, which are the cells that kind of eat the bad stuff, to basically surround and ingest virus particles. So a lot of good things there. But the classic signs of inflammation, heat, swelling, these can become problematic when they exist for too long. So when we have this inflammation, it seems to be that in cases of COVID or long COVID, whether it's because the virus hangs out in our system for longer than we're used to, because we've got excessive amounts of antibodies that are produced, or because of what we understand about the way that COVID actually seems to make our bodies go into like hyper alert mode and dump way more cytokines into the system than we would get with, say, a flu infection. All of those things in some people cause lingering inflammation that's tough to move out of the system. And that can lead to tissue damage, or at least lead to poor function in some of our tissues. And because of the way that these symptoms present and what we see, it seems that inflammation is often very present in neural tissue, brain and spinal cord, perhaps vagus nerve, which controls some of those autonomic functions in our system, like our stress response, digestion, heart rate, those sorts of things. And sometimes this inflammation is probably settling in the lungs, which contributes to the longer duration of respiratory problems that we see in long COVID. There's no reason why, a month after the infection, that you'd still have issues breathing if the virus has been cleared from your lungs. So it's got to be an inflammatory reason. So a lot of our approaches to dealing with long COVID are focused on modulating inflammation and bringing it back down into levels that are a little more normal. And coming back around to talking about the brain, these are images from a brain map, a QEEG, that we did here on a patient shortly after COVID infection. How many months after?
Well, technically, this is about 5 or 6 months post-COVID.
So this is definitely well in that range of post-COVID. We're past that first month. But what's interesting here is that this diagram shows the brain and regions of brain activity, and we see that in the yellows and reds. The red indicates high levels of brain activity, and on a normal map we would see green here too. Dr. Porter was sharing this with me a couple days ago, and he actually noted that he had to turn the scale down on this to be a legible report, because if he didn't turn it down by about 2 standard deviations, what he said, so about 2 averages down from what the normal middle of the road would be, you couldn't see anything because it was just lit up like a Christmas tree. So these areas of higher brain activity, the only reason why you'd have this wide across the board activity is if there was some sort of inflammation in the brain, because normally these ranges are much more tightly regulated.
Yeah, that's correct. And I think the brain, we can stay there a second. One of the things that we've discovered or observed is this inflammation that Dr. Seenauth was discussing it's not observable on any standard or typical labs that we're running, like C-reactive protein or sed rate, and perhaps not even like other ones that are out of the box for mold, TGF-beta1 or complement C4A. And so we don't have a way of being able to do a lab test and go, hey, you got inflammation there from COVID. Again, I think the studies are still pending, but these are our own in-office studies. But if brain maps may become a predictive measure tool for trying to observe, do we have chronic inflammation? And we absolutely see it in this patient. And prior to COVID, the patient had no health concerns, meaning she was healthy, but now struggles with neurological symptoms that are not improving with time or therapy. And so we're hoping, as we do different therapies we'll discuss shortly, we can see this change, and we may remap this patient. We hope that that'll happen, and we can compare and see if therapies that are currently being researched and things that we're doing here will reduce that inflammation. I may take a chance here, Dr. Seenauth, to someone asked a question, and maybe a good one for you and I to talk about a second. A patient asked if those patients who did not need hospital admittance, has anything been reported on how quickly they rebounded or recovered? As any reasons to why they might have needed hospitalization? So have we been able to figure out anything, like anything in their lifestyle, their diet, anything in their genetics that can predict, why some people got sicker than others, or other people recovered much more easily than others? Have you found anything at this point, research-wise or experience-wise?
I haven't really found those connections through the literature. I know that there's a lot of correlation between folks with metabolic syndrome, metabolic disease, and having more likelihood of having severe COVID illness, and that's referring to the acute illness, whether it was going to land them in the hospital or not. But I've seen some very, very interesting, contradictory almost outcomes for patients in terms of how well they've rebounded from COVID. I've seen patients who had underlying chronic respiratory disease who got through acute COVID as if it was a simple flu. Whereas, sometimes in the same house, it's the same infection, a husband and wife, and one gets over it in 3 or 4 days, and one who had no underlying metabolic disease or cardiovascular disease or respiratory illness ended up having some of these long COVID or post-COVID symptoms. So I'm surprised by that every day.
Yeah, I can say the same thing. There's nothing consistent that we've been able to observe in labs that are predict whether one patient or another would have difficulty or ease with overcoming, getting through COVID. I think what we'll probably find in the future, there are probably specific genetics that lend towards inflammation more so in one individual compared to another. And that will pan out probably the next few years with all the research. Someone asked another question too on neurofeedback as a therapy. Neurofeedback is a therapy in which once we observe like patterns in the brain that are irregular as far as delta, theta, or alpha or beta brainwaves, does neurofeedback help reset some of the health concerns we see? The specific question was about taste and smell. We do not know at this point. We're going to talk about some specific therapies in which research has confirmed it helps, and those things may help us. We're still yet to see enough research on neurofeedback, although again, it obviously may happen, and we may be able to report on that down the road in maybe 6 months or so. A lot of good questions. Thank you. Besides the inflammation, one of the changes that we see based on the research, what they're observing is the COVID is actually creating genetic changes in the brain tissue. And so these genetic changes are affecting how oxygen is being utilized or transported in the brain. We're actually seeing neurovascular changes. What that means is the plumbing that delivers oxygen and blood to the brain is being affected. And so we're having poorer or inefficient distribution of blood. And then we're also seeing that the blood is thicker. Those of you who've done ozone or who've been with us for a while may recognize that. We sometimes say, your blood looks thick. Again, a very difficult thing to test for, but we observe that by the fact that it may be darker when we observe it as a blood draw or doing ozone IV therapy. But all these symptoms or all these conditions result in hypoxia, which is a condition of low oxygen throughout the whole body. But when you don't get enough oxygen to the brain, you're going to have brain fog and you're going to have fatigue. And so when you look at the brain fog and fatigue, two of the most common symptoms you see, they could be pretty much linked to the same problem, not enough oxygen. And so again, patients will report reduced cognitive function. This is not Alzheimer's, it isn't dementia. But again, based on the previous brain maps we looked at, it's inflammation that looks like a head injury. And so you're going to have these cognitive issues, maybe short term, losing words or maybe being inefficient in your work, but remembering names or people or things that are normally easy for you to sort of observe. Okay. There's another question here. Has anyone researched if there's a link between those with genetic immune system dysfunction known as CIRS, which CIRS is known as chronic inflammatory response syndrome. And this is a condition that where we have more inflammation in response to environmental toxins, for example, mold being the leading one. I don't know. We have watched this carefully because we do treat a lot of mold patients and we have a lot of CIRS patients. And certainly those patients, a lot of them are at a higher risk of inflammation, particularly in the brain. And but again, I haven't seen that it correlates 100%. Have you seen that yourself at all?
I actually have not seen that yet. Not to say that I don't think it exists. It's a very plausible correlation in my mind. I just haven't clinically seen those patients present in the office yet. So.
Yeah, I agree. Yeah, I haven't seen them either, and it hasn't correlated well. Like I say, we have a lot of mold or CIRS immune or inflammatory sensitive patients. And again, some of them fared very well when they got exposed to COVID. Now, maybe their diets were clean and maybe they were doing a lot of good therapy and, avoiding sugar and really taking care of themselves. And maybe that helped, and maybe it did, right? Again, our patients are highly informed and educated and quite disciplined most of the time, right? And so, that could have made a difference. Other questions come up here too, looking at inflammation and hypoxia, that we're talking about viruses. Someone asked about Epstein-Barr virus and long COVID. Again, I haven't seen any correlation in lambs on this one. And again, I don't know, have you seen any other correlations with other viruses? Well, we actually have. We have, haven't we? In this, not until recent, but in January and February, we saw amongst a handful of patients, we saw in office a spike and an increase in expression of shingles, which is herpes zoster virus, which is known historically as chickenpox. And so, when you're younger, we have chickenpox, and if you get older and this virus expresses again, you get herpes zoster, which is shingles, and it presents in different ways. And it was a little confusing at first because it started out looking like COVID, acted like COVID, and then it switched in the middle to a different virus. And those patients who had this had different symptoms, and eventually it became more obvious to us. And we had actually quite a few cases. So again, I haven't seen enough evidence on Epstein-Barr, but if it can wake up, for example, zoster, chickenpox, I think it can wake up Epstein-Barr virus also. And this comes down to another whole topic of inflammation and hypoxia, which when we look at COVID and what we're discovering in the research is that this may explain why some people in the presence of Epstein-Barr may develop chronic fatigue or chronic fibromyalgia, right? And so they're saying COVID looks a lot like fibromyalgia and chronic fatigue, which is what we see with Epstein-Barr, which maybe we're starting to understand what Epstein-Barr is doing to patients long-term. So this could be very important research and helps us understand why mold, why viruses like Epstein-Barr, why Lyme keep patients chronically fatigued, brain fogged, or chronically ill for that matter. And so we hope this will help us to learn to treat and how to treat these other patient groups too at the same time in a better way. I think I'm going to mention something about vagus nerve. Is that all right?
Yeah,
okay. All right. Some interesting research. Understand a lot of the research that we're finding. The U.S. is developing some momentum, but most of the research we found that seemed to be ahead of the curve a little bit was outside the U.S. This study came out of England. They took pictures, ultrasounds of the vagus nerve. Vagus nerve arises out of the brain, but it's the only nerve that does not go through the spinal cord. So it comes out of the brain and then feeds into different areas of the body. And so it has different effects, and it can affect our heart rate. It can cause dizziness when it's impaired. It affects our breathing, our lungs. It can cause low blood pressure. We can see diarrhea, loose stools. Some people have reported difficulty swallowing. It feels like something's stuck in their throat. And of course, if you do endoscopies, there's nothing there. And so the vagus nerve would cause that symptom. And there have been reports of individuals losing their voice, which is controlled by the vagus nerve, and the muscles in this region, which are controlled by the vagus nerve. And we can see changes in sweating. Some of this looks like autonomic or autonomic nervous system type symptoms. But again, these are controlled by the vagus nerve. Again, a little complicated. And again, we don't have, sadly, this was done outside the U.S. I don't know that we have imaging that will allow us to predict this issue, but it is coming up in other countries as they study this.
It's interesting how these vagus nerve dysfunction kind of symptoms do correlate very tightly with other conditions of chronic illness that we've been discussing, like fibromyalgia, like chronic Lyme infection, like multiple chemical sensitivity or mold toxicity, and they all seem to affect the vagus nerve in similar ways. And we see this similar presentation happening again with long COVID.
Yeah, this is the first study I've ever read or observed where someone visually observed the vagus nerve being inflamed, perhaps. And these are in patients post-COVID. So again, we believe that it's COVID that caused it, and they're having these persisting symptoms. But I don't think this is a new thing. This
Yeah.
probably happened historically in many patients.
Yeah, I think that, we mentioned it earlier, as the research into COVID it continues, I think we may be able to tie this to how viruses in general affect our nervous system in different ways. I think there was a study that looked at imaging parts of the brain that are corresponded with the olfactory sensors to see if, why do we lose smell in COVID infections? Is it because of damage in the nose, or is it in damage in the brain? And
Correct.
They did find COVID virus particles in the parts of the brain that control our sense of smell. So we found that the virus does make its way there and cause some sort of damage that's associated with the symptom. So it would be interesting to see a similar study, see if the origins of the vagus nerve fibers, if that part of the brainstem is also has the COVID virus particles associated with it this far after the infection.
Yeah, I think it's fascinating. I think what we do recognize, and again, in this office, we work with a lot of chronically ill patients, but we do know that the immune system, when it's under attack, it does affect the nerves, right? As part of those tissues, whether it's in the brain or in the periphery, in the hands and the feet, or in the vagus nerve, right? These are fascinating things. Now, there have been some exciting studies and things that are going on, meaning a lot of people recognize that a lot of patients are staying persistently or chronically ill with symptoms. One of the first studies we found that seemed to be beneficial, again, in one study, upwards 10 patients who did 10 sessions, not very many, 10 sessions of hyperbaric oxygen therapy, which is a therapy in which you're in a chamber. A lot of people feel claustrophobic. As a side note, first time I did hyperbaric oxygen therapy, I had claustrophobia. I lasted about 2 minutes in the chamber. Next time I got in with some music and a video, and that was much easier. And I've been in, 40 or 50 times, 60 times since. But that can feel, again, it's a great therapy when we're put ourselves under pressure with oxygen. Again, it is shown in these studies to grow new nerves. Well, in not just recent studies, but in past studies with hyperbaric, we know it helps to grow new nerves. It reduces inflammation in the brain and grows new blood vessels. Again, that would meet the needs of the issues with hypoxia.
Yeah, it's great that this is a therapy, on label. It was designed for, decompression illness and divers, to force those bubbles back in the bloodstream. But the same way that those bubbles get dissolved into the plasma, we can force more oxygen into the tissues, into the bloodstream. And one of the cool things about the way this hyperbaric oxygen therapy works is normally, 95, 97% of the oxygen in our blood is carried by the red blood cells. But if you have some sort of issue with the vasculature because of the inflammation, your blood vessels are not permitting travel of those red blood cells through the vessels as efficiently. If we can get the oxygen to dissolve in the plasma, which is the non-cellular portion of the blood, it can get to places that maybe the blood cells can't get it to. So we can help to overcome some of that obstacle. And then obviously when your tissues are better oxygenated, they can heal better. So great tool. The study that you referenced, Dr. Porter, the 10 patients, 10 sessions, that was really, really interesting. That was measuring, all of the common COVID, long COVID symptoms. So the fatigue, the cognition, attention, information processing. So that was all looking at, brain function. I found another study that actually, this is great that there's so many new case reports being published, but another one from just last month that actually measured a perfusion MRI of the brain. So they got a picture to demonstrate how much blood flow is going through the brain, and that showed significant improved blood flow in the brain after hyperbaric sessions. And that also, they did exercise capacity studies, where they put the mask on you and run on a treadmill. And they showed that 34% increase in oxygen consumption during exercise, so more metabolism able to go on during exertion, and 44% improvement in forced vital capacity. So that's, that shortness of breath. Vital capacity refers to when you take a deep breath in and then maximally exhale. They measure how much air you can actually move in your lungs. And they showed almost a 50%, 44% improvement with.
That's pretty amazing.
So that's amazing.
Those are high numbers.
Great improvement.
Yeah.
So overall, hyperbaric treatment, a great tool.
I like that. I mean, like I say, a big fan. let me mention here, there was, throughout COVID, even into a year and a half ago, studies were reporting that ozone therapy, and again, the initial studies were in patients who were in ICUs. They were not able to do IV ozone, ozone therapy, in which we deliver ozone via a treatment with their blood. So we pull some blood out, we combine it with some ozone, and we mix it, and it brightens it up, as you might see in this picture. And then we deliver that ozone blood back into the patient, which reduces inflammation and increases energy. And we see improvements in cognition and brain fog. And the early studies in patients who are in ICU studies showed that rectal ozone administered was helping patients get out of the intensive care units. That was amazing. And so now, of recent, even in the beginning, and certainly of recent, we've seen patients come in with many of these long COVID, what we assume and diagnosed with long COVID symptoms. Ozone therapy has been used by us from the very beginning, and we're still using it in the recent weeks, and we're seeing great benefit in patients. Many patients reported feeling much better after a few sessions. We know it reduces inflammation, it improves the circulation. Again, these are similar effects you see with hyperbaric oxygen therapy, but the mechanisms are different. And so we don't know which therapy is better. There's no comparison studies here with HBOC to ozone. But again, they have similar effects. And we see, again, one effect is certainly increased stamina, less muscular fatigue. And so patients were reporting, I used to work out, I used to go for walks, I just don't have any energy and stamina to do that. And so we've seen great improvements with ozone. Someone wrote, "Oh, I love the ozone treatments." Well, again, when it works really well. And again, we've had a lot of patients positively impacted by the IV ozone therapy. Casey, you want to talk about this one?
Yeah, so frequency-specific microcurrent. This is a tool that I love because it allows us to access and influence systems in the body that are difficult to reach in other ways. So we talked a lot about the vagus nerve, talked a lot about the autonomic nervous system, which for those of you who are not familiar with that term, it's the functions of our body that we don't have to think about. So like your heart rate, your moving food through your digestive tract, things like that. So it's opposed to your somatic nervous system, your muscles, and that you consciously move. So this is kind of your central operating system. Use a computer analogy. It's what keeps you running. And if this gets out of whack, you start to see all kinds of systemic symptoms. So you said it before, and it's worth restating that there are very many conditions that we've been dealing with for a long time using alternative approaches. Conventional medicine doesn't seem to have great tools for, like fibromyalgia, chronic fatigue syndrome, mold toxicity. Mitochondrial dysfunction seems to be at the root of all of these problems, seems to be one of the main underlying factors. And that's why we have this low energy state, the fatigue, the aches, the pains, all of the brain fog. Frequency-specific microcurrent allows us to directly get to that neurological dysfunction. Dr. Porter alluded to how difficult it is to assess vagus nerve function because it's one of those nerves comes out of the brainstem, it runs throughout the whole body, and it was just a big feat that this group in the UK was able to image it. So it's tricky to be able to reach it, but frequency-specific microcurrent allows us to target that, allows us to address inflammation in the nerve, so we can treat that, allows us to reset some of those alert symptoms that people go through, the kind of danger response when there is a threat, and allows us to calm that down so that people can get into more of a state of rest, of healing, of restoring, of digestion, all of that. And great thing about the therapy is it's really non-invasive and very relaxing therapy, and it's very easy to implement. So I find this is very, very helpful. I've had a few really successful cases of treating things like lingering cough after a COVID infection, where a patient is about 5-6 weeks out, and they're like, everything else feels fine. their fever's gone, even the brain fog and stuff's gone, but they're still coughing and they don't know why. And you listen to the lungs, there's no signs of any kind of consolidation or fluid in the lungs. There's no pneumonia left over. They're not bringing up mucus anymore. It's just a cough. And that makes me think there's some sort of neurological irritant here that's causing them to cough. This is not, it's not a physical, mechanical cough at this point. So use the frequency specific microcurrent, 8-10 sessions or so, and you're able to resolve that. So
a question comes up, how is this different from a TENS unit?
Okay, so it is, there is a difference. The TENS unit, many of you are familiar with the TENS unit as a pain management kind of device. The current that the TENS unit generates is able to interact with the nerves and kind of block the signaling of pain from the nerve endings. So you turn the TENS unit on, it blocks that, and then your brain doesn't pick up on the pain, so you don't feel it anymore. And sometimes that effect ends when you turn off the machine. Sometimes it lasts a little while longer. Frequency-specific microcurrent is a little bit different in that we use targeted frequency combinations at a very, very low amplitude. So we're talking 500 milliamps or even 100 milliamps. And that range is like, what are we talking, like a tenth of a AA battery amount of current. And then we tune it to various tissues using specific frequency combinations. So we can create customized frequency protocols to target inflammation, target scarring, target other issues, and we can direct that towards various tissues. So whether we're targeting a nerve, a muscle, a vein, we can be very, very specific in the application of this current. So that's the...
Yeah, as an example, what we've said is the vagus nerve itself may affect, for one individual, the throat, or they feel like they have something in their throat, a mass or something affecting their swallowing or their speech. We can create a running program using specific frequencies that target that region or that tissue type. So it's customized therapy to the individual's needs, which is quite amazing. And frequencies are technically in itself, they are a medicine. We use homeopathy, we use herbs, but a lot of things heal via a very specific frequency. Same thing with sound and music. Those are frequencies, and we consider them to be healing. And someone mentioned blue light therapy. Yes, I agreed that any light therapy, these are all just waves and different frequencies, and there's healing in all sorts of patterns and waves and different ways that we deliver them. Light, sound, and electric. So pretty amazing stuff.
Anticoagulant therapy. So this is a very interesting aspect of COVID illness, because there's a lot of background in looking at cardiovascular disease and aspects that contribute to clotting in our veins and our blood vessels. So we've seen in both severe COVID and in post-COVID that there's an increased risk of clotting in these patients. You can have microclots, where we have increased blood viscosity. These clots form a protein in our blood called fibrin, basically congeals, and it creates these solid clumps in our blood vessels, which obstruct the flow of red blood cells and blocks the flow of oxygen and nutrients to tissues. Now, in the small blood vessels in our capillaries, that can completely obstruct them and cause tissues to become hypoxic. So I know some of you may have seen COVID toes as a long COVID symptom, where you look at the toes or even in the fingers, you get a bluish, dusky tone to the skin because there's less blood flowing through them. But also in the organs, that can lead to organ dysfunction, lead to difficulty breathing, lead to the brain fog, all these issues. Now, there was a very interesting study from December over in South Africa. There was a lot of research happening there because that's where they discovered the Omicron variant. But there was a study where 70 patients had their blood tested. All of these patients had long COVID. So they had these persistent symptoms. They tested 2 months. They defined as 2 months after recovery from acute COVID. And they did blood tests and ECGs to exclude other causes of their symptoms. So they ruled out heart disease. By running an EKG, looking at the conduction of the heart, they ruled out thyroid disease. They ruled out liver damage by looking at liver enzymes. So they were saying, these symptoms were certainly due to COVID. They were looking at symptoms of shortness of breath, chest pain, lingering low oxygen saturations, palpitations, fatigue, pain, all the symptoms we've been talking about, sleep disturbance, everything. Out of all 70 of those long COVID patients they tested, all of them showed some sort of microclot or platelet pathology in their blood tests. All 70 of them. And then of those people, they took 24 of them and treated them with an anticoagulant therapy, and all of them showed resolution of their main complaint. So the study kind of illustrates that these very pervasive throughout the population, these clots, these coagulopathies are a big contributor to these symptoms, and that people respond pretty well to anticoagulant therapy. Now, there's a lot of tools we can use to achieve that, ranging from, over-the-counter medications, specific nutritional and botanical medicines, to pharmacological interventions. But the point is that, this is an area of pathology that we do need to address in these cases, and can really be beneficial if you're addressed properly.
Yeah, I imagine that a lot of those microclots are probably driven by, the changes that as a result because of the inflammation, probably other genetic pathways. So again, we're still learning a lot about this.
Here's a little theory. This is just my thoughts on it. But we had that question earlier about what are the conditions that might predispose someone to having long COVID, or even having worse COVID infection than someone else. And one of the ones that's always talked about is metabolic disease. Are you diabetic? Are you on metabolic syndrome? Are you pre-diabetic? And we know that those conditions are associated with inflammation as well. But one thing that is really tightly associated with fibrin problems is like vitamin B12 deficiency, which we commonly see. And that contributes to having more likelihood to form clots in your system. Elevated homocysteine, which is an inflammatory marker that we look at that's associated with cardiovascular health. So folks who might be more predisposed to that without COVID in the mix, then we throw that wrench into it, and we see that they're more likely to have these problems. So,
well, we look at these are the things that we're finding currently in the research, and of course, with some time, we may find other factors that actually come into play here. Because of these root issues, particularly of inflammation, thicker blood, all this resulting secondarily or primarily due to or causing low oxygen transport through the body. This is what we believe. And again, the research matches what our feelings are at this point. This is what we've observed. And as we've applied different therapies to address these issues historically and currently, we're seeing some benefit and some results. Again, our goal is, we understand that 8%, a group of people who've had COVID will have persistent symptoms, and in a variety of different ways. Again, some of the ideas that we've presented and practiced or have applied that seem to be helpful, things to think about. If you or anyone that a family friend is suffering potentially from long COVID, again, IV ozone therapy. Usually we recommend doing this for once every 5 to 7 days, once a week as an example, for anywhere from 3 up to 5 sessions. Most people begin to respond within the first, even the second, and certainly by the third. And even after one session, we've had patients report an 80% improvement in their physical symptoms. Again, based on the studies and even our own experiments here in office, hyperbaric oxygen, it can be done as often as daily, up to 5 times a week, but anywhere between 3 to 5 times for about 10 sessions, based on the current research. Patients may need more, but I say at least 10 sessions, but we've seen and patients have reported feeling better following that treatment. And again, frequency-specific microcurrent is being utilized in very specific ways. If a patient has complaints of, say, again, a tight throat as an example we mentioned earlier, maybe they're having the AFib or other heart issues, maybe it's blood pressure, maybe it's gastrointestinal issues. Again, it allows us to customize our therapy to that specific or persisting symptom. Those are currently our leading therapies based on experience and based on the current research. The good news is we do see patients responding well. I can't say that we've had anybody fail any of the treatments we've recommended at this point, which means it's hopeful. I don't believe this is going to be a permanent state or condition. I believe it is a treatable condition. We're used to treating patients who've been chronically ill, such as with mold or Lyme or SIRS or other viruses. So that's not new to us. We know those patients do respond to these therapies also, but not to the same obvious benefit as quickly as we've seen the long COVID patients respond, perhaps. But again, we're still gaining some experience here in this regard. Casey, in closing, I think if anybody has any questions or further concerns about what we know to this point about long COVID, again, we're recognizing at this point that more patients are suffering with long COVID. It took us a little while to see that that was going to be a concern. Of course, no one knew a year ago or even really 6 months ago, but it's obvious today that this is a rising problem. Again, as a reminder, we're going to see anywhere from 10 to 30% of the population on average having some persistent symptom following a history of COVID. The harder it was for them in the beginning, the more likely they are to have a symptom. But even those who weren't hospitalized may have persisting symptoms. We've tried to answer questions, particularly as we went along and or as they seem to be pertinent to the slide or the presentation. Again, at this point, we have finished our presentation. And if anybody has any other questions or concerns, we'll take a few questions here at the end. Again, we try to answer them. Hopefully we got them. If we missed you because of our just not paying attention, then please answer or ask your question again. But we appreciate everybody joining us, and we hope that we find this helpful to somebody as we want everybody to feel their best and to recover as quickly and as soon as they can. So thank you, everyone. We don't see any questions at the moment.